I want to thank the organizers very much for having me here. It's been a great meeting. Now, I usually try to be entertaining, but after Dr. Sobrero's outstanding discussion, I won't be measuring up to that level of entertainment. So I'll do the best I can. I'd also compliment the three speakers who just preceded me for really crystal clear presentations, and I will try to put them in perspective, but they really spelled it out very nicely. So I'm calling this Myths and Realities in Colorectal Cancer. These are my disclosures. I've served on the Data Safety Monitoring Board, by the way, as well, for bevacizumab, just to clarify that. So I'll talk about what I think are some myths. I'll review the data, which you just heard, and it was presented very clearly, so I won't spend much time on that. We'll talk about the realities and what the take-home messages of these are. There's some myths that we live with in oncology. One of them is that the age of the patient is important in deciding treatment and that we should go easy on the elderly. There's a myth that we understand the RAS pathway and its mutations. And there was the myth that preventing oxaliplatin neuropathy is as simple as infusing calcium and magnesium. We just heard those myths discussed. The data came from three studies: AVEX, which was bevacizumab in the elderly; the mutational analyses of PRIME, really a very nicely done work; and the oxaliplatin neuropathy prevention just presented by Dr. Grothe. All excellent and, I thought, clear presentations. So I'll just spend a moment talking about the results. This is the AVEX design, as you saw. Elderly, and as I get older, you have to be careful who you call elderly. It was defined as greater than 70 years of age, and this was an analysis of subsets. Now, who are these patients? We in the United States attempted to do a study in the elderly, and frankly, the elderly don't like being called elderly, and they don't like being told they're elderly. And what's elderly is changing. It's everybody else is elderly and not the person you're talking to. So that's something we were unable to do, and I would give great credit to the UK, the group, Dr. Saunders and his group for accruing this study. Now, we're told these are patients who are not optimal candidates for combination chemotherapy with irinotecan or oxaliplatin. I don't know who those are, but I suspect there already in this study may be a bias against treating elderly patients aggressively, because I think if the patients were candidates for chemotherapy, I would think some of these, if not many, might have been candidates for irinotecan or oxaliplatin. So these are study patients who somehow somebody thought weren't candidates for aggressive therapy. They were greater than 70 years of age. Here's the forest plot, as you see. And on the left, you'll note the numbers. They're small numbers in the group greater than 80, and about 100 patients each in the subset 70 to 74 and 75 to 79. You'll note that the PFS favors the addition of bevacizumab in each of the subsets, but it doesn't, in terms of overall survival, the numbers look positive, but they're not. It's not powered adequately to show an overall survival advantage, but there is a progression-free survival advantage. Now, these numbers, 20.7 versus 16.8, this is actually nice, very good survival for patients of this age. Again, there's the hazard ratio that didn't meet statistical significance. Their conclusion was that they demonstrated a statistically significant improvement in progression-free survival with the addition of Bev, and that this suggested that you could be aggressive in elderly patients. Now, if you can be aggressive in elderly patients, perhaps we should have used oxaliplatin or irinotecan in these patients, and again, that's just one thing I'm not clear on. So the myth that I talked about, age is important in deciding treatment and we should go easy on the elderly. Well, what does this show? First, again, I would compliment the investigators. This is a very important subject, the issue of age and how we treat these patients, and kudos for them for completing the study. However, these are elderly patients who were eligible for clinical trials, who could tolerate Bev. They got the progression-free survival advantage, but they couldn't tolerate irinotecan and oxaliplatin, and they didn't get an overall survival advantage. I have a little bit of trouble squaring that. And I suppose my principal issue with this study is that age is not really the right parameter for determining how to treat the elderly patient, I would argue a frailty index or some other index that measures some of the activity levels and other factors that reflect age, and as well as comorbidities, might be a better way to look at it. But nonetheless, I think this is an important study. We see in the adjuvant setting, however, that, for example, FOLFOX may not be conferring benefit to patients as opposed to infusional 5-FU. So the issue of treating the elderly remains open to question, and again, I think this study suggests that we could ask the question, although I might use a frailty index rather than just the numerical age. Dr. Douillard gave a very good presentation, a very important presentation, which is a retrospective biomarker analysis of data from the PRIME study. PRIME, again, as he described it. The ascertainment of these biomarkers was quite good, considering that this was retrospective. I should say that this group does just outstanding biomarker work and has informed the field very dramatically over the years. I remember when the study began, we didn't know about KRAS, and so this is really a tour de force to get this kind of data. Here's a forest plot, as you see, the outcomes favoring PMAB and FOLFOX versus the FOLFOX alone. And as Dr. Douillard showed us and pointed out, it turns out that any RAS mutation is suggestive of failure to respond to an EGFR antibody, in this case panitumumab. The 17% of the patients with wild-type KRAS in this study had other RAS mutations other than the 12 or 13 codon mutations, and while the PFS and overall survival were numerically worse in the PMAB and FOLFOX arm in those patients, so suggesting a deleterious outcome if KRAS or if RAS mutant, this did not reach statistical significance. So do we understand the RAS pathway and its mutations? It may be that any RAS mutation signifies poorer outcomes and lack of response, and I agree that we should undoubtedly be looking at all RAS mutations or many RAS mutations, and that's an important discussion to move forward. Now, what about what Dr. Grothe just presented very clearly, and this was the question of whether or not calcium and magnesium could prevent oxaliplatin neuropathy. You saw the data, you saw the progression, a study that initially suggested a benefit that was curtailed because of a data safety monitor intervention, believing that there might be a poorer outcome for patients related to cancer who got calcium and magnesium. Here's a design, double-blinded. This is a very well-conducted study with very elegant, sort of very cool tools to look at neuropathy, really probing this very carefully and aggressively in patients. And if that's not a negative curve, I don't know what is. Clearly no delta in sensory neuropathy nor in sensitivity to cold. Now, this surprises me, frankly, not the conclusion, which I totally agree with. Over the broad population, this therapy clearly did not confer benefit to patients. But as an oncologist, I think I can attest to a handful of patients who had crippling cold sensitivity with their first or second cycle of oxaliplatin, who had no cold sensitivity when they subsequently were pre-treated and post-treated with calcium and magnesium. At least anecdotally, I believe we've seen that. And so I think we have to remember broadly across populations, therapies may not be effective, even though they may be effective for an individual patient. So can we prevent oxaliplatin neuropathy with infusion of calcium and magnesium? Well, no, not broadly, and I think the take-home message here is when something looks too good to be true, it probably is too good to be true. Now, what are the take-home messages? Well, I think part of what the take-home message is what we think we know we may not know. That's sort of Dr. Sobrero's convoluted explanation for one of the studies. I think clinical research may tell us what to do for the individual patient, may not tell us what to do for the individual patient. For example, is Cape-Bev right for every 80-year-old? Probably not. Is age the important factor of comorbidities? That's open to discussion. EGFR may not be appropriate for all patients with RAS mutation, but may be appropriate for an occasional patient, perhaps with a specific mutation. And I would say calcium and magnesium may be useful for an occasional patient based on anecdote, but broadly those should not be done. My final myth is that CLGB-SWOG 80405 is an important study, and we await the results to inform our next steps. I've heard that numerous times, and of course I'm shameless because that's a study that I led in the cooperative groups in the U.S. To remind you, CLGB 80405 used to look like this. This is when it started in 2005. That's 8 years ago. Three-arm study looking at a single biologic, dual biologics with either FOLFOX or FOLFIRI as the backbone. This study has morphed over time, a lot of time. You see here, these are the Dear Doctor letters in the U.S. that we wrote to investigators every time we made a substantive change. There were, I believe, 7 Dear Doctor letters. These included, at one point, not allowing calcium and magnesium because of the sense that it might be deleterious, then allowing it, then not allowing it. We stopped the study for over a year for KRAS determination by the FDA, central review, then we moved it to local review. We also, in the U.S., believe it or not, deal with 5-FU and leucovorin shortages. So you can't get 5-FU. So we had lots of obstacles, and not the least of which was we realized that the double biologics, at least with the backbone chemotherapy, were not going to be helpful. So the study, as it ended, looked like this. This is a Bev versus cetuximab frontline study, dealer's choice for the chemotherapy backbone. We did enroll 1,177 patients to this final endpoint, a total of 2,334 patients to the entire study. I'm shamelessly advertising this, but we expect the clinical results to be available or to come to fruition in the next 4 to 5 months. The reason we don't have results yet is patients have lived surprisingly long on both arms, apparently approaching 30 months on both arms. Now, what we hope to do as we move forward is deal with the myth. CLGB-SWOG 80405 is an important study. I believe it is an important study. We anticipate the results soon. The correlative studies are ongoing and will follow at ASCO, and perhaps I'll get to present them here next year. Thank you for your attention.